So I think to wrap up, we'll just talk a little bit about ctDNA again. I think 2025, we saw some updates with kind of moving ctDNA beyond prognostic data to trying to really find a home in terms of clinical utility. I think we saw some data from Altair earlier in the year looking at the addition of Lonsurf for ctDNA positive patients, and then the Australian group presented Dynamic 3 yesterday. A little bit surprising. So, like, how do you make sense of like the ctDNA data that we have in terms of, you know, can we actually, with the data sets we have, think about using it beyond just as a prognostic biomarker right now? Stacey, you want to? I know, I was like, Stacey.
I mean, I would say prognostically, I think we have the data. I don't think we need to continue to rehash the issue, but prognosis only matters if we can change management appropriately and get better outcomes. And I think that we've looked very broadly, which is great for generating new ideas, hypothesis generating, but to really move the needle, I think we need to narrow down. And so we need a specific setting, we need a specific chemotherapy regimen, and a little bit less sort of provider choice or physician choice about how decisions are made. So we know that we all have our own biases and there's variability, I would say even maybe more globally, as we saw in Dynamic 3 for what's done in the adjuvant setting. And so I really look to Circulate North America to hopefully answer this question, which is stage 3 colon cancer has been resected, and it's a ctDNA-driven adjuvant therapy selection with clear regimen choices, clear durations, and I think that that's really where we need to go, is to kind of remove us out of the picture. I think we are muddying the waters as much as we're trying to help it, and I hope that that will help answer the question. And I truly hope that it is predictive, because we think we're, you know, harming some patients with toxicity that don't need it, and we're probably missing the chance to be more aggressive when we should.
Fully agree.
Yeah. The Dynamic 3, you know, read out that escalation part, right? And so, you know, I think we still hopefully will get some results out of the de-escalation, which, you know, really is probably, you know, we are, as you mentioned, over-treating so many patients just because we don't know who, and so we'll have to see, and I think that may, at the end of the day, may be where all of our adjuvant studies really provide the most value. You know, to escalate, you need a good biomarker, which we think we have, right? And you need a good therapy, right?
Yeah,
which we don't, right?
So that's a great opportunity for drug development. If Circulate US is not going to be positive, I mean, we really need drug development in this area.
Yeah, we need to bring novelty.
Fox or
something
for
more than 70 years.
Yeah, exactly.
So the way I look at Dynamic 3 is that it was a tremendous effort, but it was leaning on going from 3 months of FOLFOX to 6 months of FOLFOX, which we know is minuscule at best, and then the addition of irinotecan for some patients, which, you know, may not, you know, it's arguably the best standard of care tool maybe we have to test at the moment, but we just don't, you know, we just don't know. So novelty is certainly needed. But I mean, Aparna, you're working hard in this space, right?
I'm working hard in this space.
Yeah.
Well, I mean, I think these trials are just really hard to do. I think, you know, I really applaud the Japanese and the Australians for what they've been able to do. But I think as a community, I still think we actually need to promote the testing. I know there's a lot of concern because of the lack of clinical utility data, but only if we're testing can we find the patients to do the trials. And so really trying to coalesce some efforts to promote testing, but not just in vain, but to have programs like you guys have and Intercept at a scale that's, you know, that we can do here to bring the trials, the novel therapies in this space. You know, and I think the de-escalation is, you know, so important, as we're alluding to. And like, we know these patients do well when they're negative, but there's still the sensitivity issue, right, of the stage 3 patients and kind of missing. And even what we saw with the original Dynamic, right, the T4 patients still did not great, right? Yeah. Even, so is anyone currently using, I mean, I'm just curious, is anyone using it to actually guide their clinical practice today, and in which scenarios?
Oh, for early stage disease? I think all it makes us do is maybe in regards to follow-up, in regards to surveillance, maybe that's the only thing it may be impacting. Instead of waiting for that annual CT scan, if you have somebody with a positive circulating tumor DNA, maybe get a CAT, you're going to get a CAT scan a little bit earlier. But in regards to changing therapy, I don't think we have, outside of a clinical trial. I will use it in the stage 2 patients that we've had that conversation, and they'll say, I don't think I want to do adjuvant therapy, and I'll say, great, hold that thought. Yep. Jimmy, let's test, and if it's, that's
and
fair
then,
for stage 2.
Yeah, and I think where that even comes up is, we understand when you're the positive predictive value, and you can have false positives with stage 2 patients too, but the clinical features we use to guide our adjuvant decision making aren't. The PPV is not great either, right? So I agree. I actually do test my stage 2 patients, and then if there's older patients, stage 3, and you're like, oh, should I give or not? And
I have done that.
so like I'll test it in sort of a tiebreaker type of thing. But
even stage 3, I think it could be helpful, because what if you start your patient because you for sure want to give them adjuvant therapy, but they just don't tolerate it well, or they kind of begrudgingly go on adjuvant therapy, but they really would rather not have poisons in their body, sort of ideas. And I think that in these situations, it can help you sort of really address the impact of adjuvant therapy might have, versus tell them that maybe there's somebody who's negative, and perhaps 5FU alone is okay, or stopping early is okay, or modifying according to their goals.
And then of course in that rare case of DPD deficiency, where you can't give them adjuvant therapy.
But yeah, I think just before we wrap up here, to echo on Scott's comments, is I think the therapies that have been tested in these trials, like Altair with Lonsurf, and then a little irinotecan, and then just additional oxali, I hope that doesn't discourage development in this space. I think it's really important to not yet say that, well, nothing is going to work. We don't know that yet. And I think support efforts in this space, because I do think we still have an opportunity to cure more patients, and we just need better therapies. Any other final comments? This is awesome that there's so many things for us to talk about that are so meaningful for our patients, and I think the time is now for colorectal cancer. So.